I think we should get it started because we have a lot of presentations and we want to have some discussion at the end. It's a great pleasure and honor to invite Dr. Michael Jaff. I don't think he needs any introduction. He's going to be discussing the epidemiology and prognosis of critical limb ischemia. Thank you, Michael, for coming.
Thank you, Mehdi, and to all the course directors. An honor to be here today and to participate in this important session. I'm presuming this is one of the reasons that everybody's come to this meeting, because of all the areas of growth and hope and opportunity in peripheral artery disease. It's the patient with critical limb ischemia that we have a great deal of anticipation. Finally, it's been about time, right, Mehdi?
That's right.
So I'm just going to set the stage, and then the stuff you really came to hear will follow me. You saw my conflicts already, but in case you missed them, here they are again. So, I never seem to have trouble showing a picture like this, and everybody kind of knows, well, that's a bad thing. That's the most severe manifestation of peripheral artery disease. And I think we all know the basics, that patients who present with this often have multi-level disease. The prognosis of patients with critical limb ischemia is particularly sobering. And there are a number of both macro and microcirculatory mechanisms that lead to this terrible outcome in patients with CLI. From a macrocirculatory standpoint, obviously it's diffuse, severe, often heavily calcified atherosclerosis throughout the limb, and that the ability to compensate for this over time is relatively meager. So collateral vessels really don't offer enough. Local autoregulatory events, vasodilatory effects, distal to an occlusion really are relatively impotent in preserving a limb that's faced with this degree of disease. But in addition, the microcirculatory impact really compounds the problem. This is actually some work from Victor Zhao suggesting that all of these effects at the cellular level, including microthromboses, platelet aggregation, all of these lead to just a poor outcome. There's been a bunch of studies that have looked at the basic portfolio of the population of patients who get critical limb ischemia. This is from 2009, looking at a population at high risk for CLI, members of the U.S. Veterans Administration. And you can see when you look at this that, a large portion of these patients have diabetes, a significant portion are smokers, either current or past, and about 40% have chronic kidney disease, a risk factor that must be considered for every patient who you see with critical limb ischemia. In fact, just looking at that triad of diabetes, chronic kidney disease, and peripheral artery disease really is sobering as you move from those with normal glomerular filtration rates, in which there's really not a huge difference between those with diabetes and those without. You'll notice here that the prevalence goes up quite drastically in both populations as renal function gets worse. But more recently, this data that Mehdi knows quite well suggests a very modern look at the patients who suffer from critical limb ischemia. This is an excellent study looking at readmission rates for patients with critical limb ischemia, looking at almost 61,000 hospitalizations in a one-year period at a cost of over $600 million for readmissions. So I won't go through the details of the paper, but I will show you that, again, a large prevalence of cigarette smoking, diabetes, over half the patients. Notice here about a third of the patients have chronic kidney disease. So this is a very, very high-risk patient population. By the way, in case you haven't seen this paper yet, 1 in 5 CLI patients are readmitted within 30 days. 1 in 5. That's where the $600 million for the readmission comes from. That's not talking about their index care. So the guidelines often we would think would help us in understanding the epidemiology and the outcomes of patients with PAD. So I cited the most recent multi-societal PAD guidelines. And you can see here that when you look at the management of CLI, they talk about a condition in which the constellation of symptoms and signs are proven objectively by these tests. I could spend a lot of time, it's beyond the scope of my discussion, to talk about the flaws in that statement. Medi's published some seminal work on the inability of using ankle brachial indices and toe brachial indices to objectively define who has critical limb ischemia. When you look at the issue of preventing tissue loss in patients with PAD, the guidelines specifically talk about the importance of self-foot examination, healthy foot behaviors, things we don't do particularly well or routinely. This is one of those things that you could have a regular handout that if you don't talk about it with your patient, your nurses, nurse practitioners, physician's assistants certainly ought to. And then I think a concept that's starting to gain real momentum, not only because of the guidelines, but also for things like the BEST CLI trial, has been this ability to recognize the importance of a multidisciplinary approach. Now, you may not agree that you need colleagues from other specialties for the interventional management of patients with critical limb ischemia, but I would say that it would be arrogant of you to think that you don't need other subspecialists to help you with the comorbidities, including chronic kidney disease and diabetes, certainly the importance of counseling around smoking cessation, and then critically, the importance of wound care and foot care management after the intervention. In this paper published again by Medi in 2016, looking at the hospital admission and outcomes, you can see that in almost 650,000 admissions over 8 years, there's some optimism to look here. For example, despite the fact that the admission rates for CLI were going up, the amputation rates appear to be going down, as are mortality rates, certainly trending in a better direction. And one might presume that the mortality rates are going down from more aggressive systemic risk factor intervention. I would certainly suggest that one would hope that the amputation rates reducing are due to earlier recognition and more aggressive and prompt intervention, regardless of your strategy. And a bunch of us worked on this expert consensus guidelines document, which suggested this algorithm for the diagnosis and management of CLI. And I just want to raise the fact that one of the things that in the United States we don't do uniformly well is consider intervention in anyone who presents with critical limb ischemia. I think this is one of those concepts, I always say in medicine you can't say always. I'd say virtually always you should at least think, what are my revascularization options for a patient who presents with critical limb ischemia? You may end up deciding that amputation is the best strategy, but at least give the person a chance to think about it. To prove that there's such variability nationwide, this was a Phil Goodney paper that was published that looked at patients who underwent a major limb amputation in the year prior to this study, 20,000 patients. You can see here that only 46% of these patients had an intervention 1 year before the amputation. Only 46%. That means 54% did not. Well, you want to feel even worse about this? Look at what the interventions were. In this, 17% only had a diagnostic test, like an angiogram, hardly an intervention. So if you actually add this up, far fewer than half of the patients with critical ischemia ending up with an amputation had an attempted revascularization in the year prior. And you can see here that it varies widely from low-intensity revascularization regions of the country where only a third of the patients had an attempted revascularization to in the very highly intense intervention areas of the country where only 2/3 of the patients had an intervention. So in the best of situations, at least 1/3 to 40% of patients with CLI don't ever come to a consideration for intervention. That's an embarrassment for all of us. Now finally, the prognosis. Well, the prognosis without an intervention is particularly grim. 1 year after the diagnosis of CLI, 25% of the patients will have died, 30% will be still alive but will have had a major limb amputation. The 3-year limb loss rate's about 40%, and the quality of life of patients with CLI are similar to patients with end-stage malignancy. If you look at what happens to these patients, again, another publication from Medi, you can see that he's clearly focused on the CLI population, and you look at those patients who get readmitted, almost 30% are readmitted for cardiovascular reasons. But when you actually look at this, look at the fact that 10% are readmitted for rest pain. So that's not insignificant given that they had already had a hospitalization treated with endovascular therapy. Notice here about 5.5% had procedural complications. So a really very sick, high-risk patient population. And when you look at the risk of having a major adverse limb event or dying, the prognosis of patients who are readmitted is dramatically worse than in those who are not readmitted. So a successful intervention at the time of index hospitalization and a team approach to the management after discharge has to lead to a better likelihood of resulting in no readmission in 30 days. And I would say you got to work hard on that because you can't afford your patient to end up in this readmission group. Look at that outcome. 2 years. It's really sobering. This has come to the attention of the federal government. This was a paper that we wrote a couple of years ago in an effort to bring everybody together to petition Medicare on the importance of coverage for PAD interventions. I believe Mehdi talked a little bit about this at the opening of the meeting today, but drug-coated balloons are on the blocks for losing their pass-through code, which could seriously harm our ability of our patients to get this therapy. You'll notice that in the prognosis about CLI, the cornerstone of treatment for CLI is improvement in perfusion through revascularization. In the absence of successful revascularization, up to 40% will require limb amputation. So I think this is a high-risk population, and we're going to hear a lot of great things about the future going forward. Thanks very much for your attention.